I'm going to talk about causal inference methods for real-world evidence, and we're going to see how these work in a case study of a target trial emulation. Okay, first, I would like to describe what causal inference is and how is it different from other tasks that we can do with data science. With data, we can do three things. The first task of data science is description, which is very straightforward. Description is just using data to provide a quantitative summary of certain features of the world. For example, one question that can be answered with a simple description is what is the cumulative incidence of COVID-19 in the US? We just have to count the cases and describe that incidence. The second task of data science is prediction, which consists on using data to map some features of the world to other features of the world. One question that can be answered with prediction is who is at higher risk of developing serious complications of COVID-19? We just have to collect data about patients that have a COVID-19 and then map which characteristics might confer them a higher risk of having complications. And the third task is causal inference, which is using data to predict certain features of the world as if the world had been different. This sounds complicated, but this is what we do when we run randomized clinical trials. And the examples of questions that we can address using causal inference is, does drug X work against COVID-19, or is drug X safe? The main difference with prediction is that in the first example, I might estimate that age is a risk factor for having complications of COVID-19, but I cannot change an individual's age to prevent complications. On the other hand, in causal inference, if I estimate that drug X is effective for preventing complication, I can decide whether to use or not that drug to treat patients. Okay, I'm mentioning this and I want to make this clear because when the FDA issued this program, they say that this program had to evaluate the potential of real-world evidence to help support approval of new indications or to help support or satisfy post-approval study requirements. Implicit in this is the causal inference flavor of the analysis. We want to estimate whether some drugs are effective and safe. Okay, the truth is that people are usually reluctant towards real-world data. Real-world data are just observational analysis, observational data. But on the other hand, the scientific community believe randomized clinical trials blindly because they are considered, for a good reason, the gold standard in clinical research. So why is there reluctancy towards real-world data among the scientific community? Because of results like this. Here on the left, I have a table with 4 observational studies. In this case, they analyze the effect of taking statins on the incidence of cancer. And they found consistently very, very protective effects. Here on the column on the right, you see the odds ratios, and they are very protective, up to 0.23, which is an incredibly protective odds ratio for taking statins. And these were studies published in major journals. They were published in the New England Journal of Medicine, JCO, American Journal of Epidemiology. Okay, after reading this, it sounds like we had to put statins in the tap water. But when you run 20 randomized clinical trials and meta-analyze the results, we found that the odds ratio of cancer for taking statins is null, is 1.02. So what's going on here? The main answer, the usual answer that you get is, well, you know, this discrepancy is because you don't have randomization. In a randomized trial, you have randomization, so there is no confounding. In observational data and real-world data, you don't have randomization, so that must be the reason. If that is true, there is no solution to that. If there is a measure confounding, there is nothing we can do about that. If that's true, real-world data might be useless to address this specific question. But there can be other reasons. And these other reasons are just deviations from basic principles of study design, like misspecification of time zero, a misspecification of treatment strategy, a misspecification of causal contrast, selection bias, and others. The difference with a measure confounding is that this deviation of study design can be fixed if we use a proper approach. And the approach that I'm going to propose here is called a target trial emulation. And we're going to see how it works for real world data with a case study. So what is emulating a target trial? It sounds fancy, but it has been out there for decades. And it's just an exercise of causal inference. Causal inference, as I mentioned at the beginning, refers to a contrast between average counterfactual outcomes under different treatment values, which means that for every causal effect, I should be able to imagine what would be my hypothetical ideal randomized clinical trial that I would like to run. If I want to estimate the effect of this drug on the outcomes of COVID, I should be able to imagine what trial I would run if I had the money, the time, and the patients to run it. So the first step to emulate a target trial is writing down what is my ideal trial, what is the target trial that I would run, and write down all the components, the same as you would do with a real trial, the eligibility criteria, the treatment strategies, how you assign treatment, outcomes, follow-up, causal contrast, and statistical analysis. And once we know all those components, we can use specific methods to emulate each of those components in my real world data analysis. And we're going to see how that works in a case study. Okay, why the trouble of doing all this? Why not just compare users of one drug versus non-users of the drug? The main advantage of emulating a target trial is that your intervention will be well defined. It will be very clear what you are studying. The technical term for that is consistency. Once we have a well-defined intervention, then it's very easy to address the other two identifying assumptions that we need for causal inference, which are exchangeability and positivity. And as a plus, when we emulate a target trial, we guarantee that we are aligning eligibility, treatment assignment, and the beginning of follow-up. And that is important because that will save us of different biases in form of selection. Example of selection biases for misalignment of these components are the use of prevalent users and immortal time bias. And also, when you discuss a research question around the design of a randomized trial, it's easier to communicate with collaborators because you don't have to go into the details of when am I censoring people, which person time am I comparing, etc. It's usually a very good starting point to discuss a project. Okay, before we jump into our case study, I wanted to share with you this reference. This study, we published it last year in Nature Medicine, addresses the question of the use of statin on cancer incidence, the discrepancy that we saw before. We saw a huge discrepancy between observational studies and real randomized clinical trials. Here, we used observational data, real world data, and this target trial emulation approach to estimate the effect of statins on cancer incidence. And what we found was that the effect was null. The pool hazard ratio of the 20 randomized trials was 1.02. The hazard ratio that we obtained here and then intention to treat approach was 1.02. So in that specific scenario, the discrepancy was not because of measure confounding, because we are using here also real world data. The discrepancy was because of errors in basic design of the study that are solved when we use a target trial emulation approach. Okay, but we are gonna study this case study here because it's a little more involved and will give me the chance to explain more nuances about how to emulate a target trial. This work was published this year in Annals of Internal Medicine, and it's about continuation of screening mammogram and breast cancer mortality in women over 70 years. So why is this article important? You probably know that screening mammogram is a well-established program in many countries to prevent breast cancer mortality. And it is for a reason, because there are many randomized clinical trials that have shown that it actually prevents breast cancer mortality. If we look at the most recent meta-analysis, we see that initiating breast cancer screening between the age of 50 to 69 and continuing it for 10 years prevents about 2 breast cancer deaths per 1,000 women. In a slightly older age group, in women aged 70 to 74, it prevents about 1 breast cancer death per 1,000 women. But here the confidence interval is wider. It goes from preventing 3 deaths to causing almost 2 deaths. And for older women, for women over 74, we don't know. We have no idea because randomized clinical trials did not enroll a single woman over 74-year-old. But there are women out there over 74 that are wondering whether they should continue receiving breast cancer screening or not. If we go to the guidelines, we found that, for example, the USPSTF says that the current evidence is insufficient to assess the balance of risk and benefits of screening over the age of 75. If we go to other societies, they say that, well, you have to rely on life expectancy. But they say that without any evidence. The truth is that in the US, over half of the women over 75 receive breast cancer screening. So it's something that is happening and we don't know whether it's effective or not. And 1/3 of breast cancer deaths happen in women over 70. So it's a problem. There are breast cancer deaths that needs to be prevented and we don't know whether screening is the way to do it. So in this study, the research questions were in women aged 70 to 74 that are currently being screened, what is the effect of stopping screening versus continuing screening for 8 more years? And the second research question is the same, but in women over 75. In this study, our real-world data are going to be Medicare claims for research. We're using Medicare because every year in the US, over 40 million mammograms are being performed per year. And 1/3 of those are received by Medicare beneficiaries. In this study, we use the research identifiable files, a 20% random sample of Medicare that contain services received in an outpatient setting, though admissions, physician services, the cause of death, and it also contains some chronic conditions that are extracted with algorithms. We use the years 1999 to 2008. For this study, the advantage is that screening mammograms have a specific code and an algorithm exists that improves the specificity for identification of screening mammogram in Medicare claims. Okay, so you might be thinking, well, you have your research question, you have your data. Why don't you just compare women that receive screening for 8 years with those women that didn't receive screening for 8 years? Well, because you would be running into an immortal time bias. You would find, and this is a real analysis, I actually did that analysis. You would find this huge protective effect of continuous screening for 8 years. Because if you just compare women that receive screening for 8 years, by definition, they were alive for 8 years. They didn't die because of breast cancer. So mortality there is close to 0. So this is a bias analysis and you shouldn't run into this. So how can we properly analyze this then? In this case, we are talking about estimating the effect of different durations of treatment. When you want to estimate the effect of different durations of treatment, you have to follow a stepwise approach. And this was described recently, a couple of years ago, by Miguel Hernan in the British Medical Journal. And this approach consists on 3 steps. First, you have to assign individuals to the treatment strategy, to the screening strategy at time 0. You don't have to look into the future like the slide before. You have to assign people at baseline. To do that, you need to clone individuals, and we'll see how that works in our example. The second step is selecting only the person time that are compliant with the assigned treatment strategy. To do that, you censor individuals when they stop following the treatment strategy that they were assigned to. And the third step consists on adjusting for the potential selection bias introduced by the previous step. Because people that adhere to a treatment strategy might do it for a reason, or maybe those that didn't comply with the strategy did that for a reason too, because they have another health problem in the middle during the follow-up, etc. To do that, we will have to use inverse probability weighting, and we will see how it works in our example. Okay, so what we are going to do here is first think about the ideal randomized clinical trial that we would do to answer our question of whether to continue screening or not. And then once we have this synopsis of this protocol written, we will see how we can emulate each component using real world data. Okay, this is table 1 of that publication. In this table 1, we did this exercise of writing what is our target trial, and we're gonna go through it and then we will see how we emulated each component. The first component of our target trial is eligibility. For our study, we will want to study women aged 70 to 84 without prior breast cancer, with a good life expectancy, and without breast symptoms. Our treatment strategies are stop screening, which means that after randomization, the woman assigned to stop screening do not receive further breast cancer screening, or continue screening. That means that women assigned to this group will continue annual screening mammograms. Under both strategies, women are allowed to receive a mammogram if they have symptoms. They can receive diagnostic mammograms anytime. And once they are, if women in either arm are diagnosed with breast cancer, they don't need to follow screening anymore, because by definition, screening is for asymptomatic, disease-free population. In our target trial, in our ideal trial, women are randomized to both strategies, and they are aware of the strategy they have been assigned to. The follow-up in our target trial starts at the time of treatment assignment and continues until death or disenrollment from Medicare, whatever comes first. The primary endpoint is breast cancer mortality. Our causal contrasts are going to be an intention to treat effect and the per protocol effect. And the statistical analysis for the intention to treat analysis is pretty straightforward. It's a marginal comparison. But for the per protocol analysis, even if we are in a randomized clinical trial, we need to introduce some adjustment. For those women that are in the stop screening group, they will be censored if they start receiving screening sometime during the follow-up, because they are deviating from the assigned group. For those in the continuous screening group, they are censored at the 14th month after the last mammogram if they did not receive another mammogram, because mammograms are to be received every year. Here we are using a grace period of 3 months. So those that don't continue screening will be censored. This censoring needs to be adjusted for, even if we are in a randomized clinical trial. And to adjust for that, we will use inverse probability weighting that will adjust both for baseline variables and for time varying covariates. Okay, now we have an idea of what would be our target trial. Let's see how we can emulate that using real world data. Regarding the eligibility criteria, we're going to use exactly the same eligibility criteria. One of the eligibility criteria of the target trial was having a good life expectancy, and we surrogated that by having a comorbidity score lower than 1 that corresponds to a perceived life expectancy of more than 10 years, more or less. The treatment strategies are the same, and treatment assignment in the target trial, we were randomizing people. In our real world data emulation, we don't have randomization. We're working with Medicare. There is no randomization on Medicare. So what we are doing here is assuming that within levels of all the confounders within levels of all the variables that we think can be common causes of receiving a screening and of dying of breast cancer, as treatment assignment happen at randoms, which means that we have done a good job in measuring all the potential confounders and then adjusting for them. The follow-up is going to be exactly the same as in the target trial. The primary endpoint, breast cancer mortality, is the same too. The causal contrast is going to be the observational analog of the per protocol effect. So we're going to estimate what is the effect of actually adhering to the strategy that you have been assigned to. And the statistical analysis is going to be exactly the same as in the target trial, where we have to adjust for adherence in the per protocol analysis, with the exception that because we don't have random assignment, we will have to use clones. We will create 2 individuals per eligible woman and we'll assign 1 individual to each screening strategy. And we're going to see how that works in a couple of slides. Okay, so far it sounds easy. We have an idea and we have a plan to emulate a target trial using that idea. But we run into 3 problems. The first problem was that my eligibility criteria was age 70 to 84. So what happens if a woman receives annual mammograms at age 71, 72, 73? Women are received every year. So when should I include her in my cohort? Here we have 2 unbiased choices. We can use a single eligible time. We can let people contribute to our analysis only once. And that single eligible time can be the first time they are eligible, or just a random time. From all the times that woman is eligible, just pick one at random. Or, and this is more efficient, we can choose every eligible time. Whenever a woman is eligible, she will contribute to our study. This second approach is more efficient, and here I've pasted a reference where we show that that is actually more efficient. Okay, problem number 2. What happens if a woman dies of breast cancer, suffers the outcome of interest, without receiving a mammogram at month 8 after baseline? This woman is being compliant with both strategies. She's being compliant with the stop strategy because she did not receive another mammogram after baseline. But she's also compliant with the continue strategy because she may be planning to receive a mammogram at month 12. What can we do here? Here we can either randomize my sample to both arms, so that outcome will fall at random in one of the groups, or we can clone individuals. And this second approach is more efficient, and I'm going to show you how it works. Cloning means that I literally make a copy of my database. If I have 1,000 women, I will copy them and I will have a database with 2,000 women. I will assign 1 copy of each woman to the stop screening group and the other copy to the continuous screening group. Those copies that were assigned to the stop screening group are being followed up as long as they don't receive more screening. But if at any point she receives a screening mammogram, that's the censoring event for her. The copy assigned to the continue group will continue to follow up as long as she continues receiving a mammogram at least every 4 months after the prior one. If this copy does not receive a mammogram by month 14 after the last one, we will censor her at that time point. And the third problem is the selection that we might be introducing by that artificial censoring. We are actually comparing adhering women with non-adhering women, with adhering women in both groups. And this is a problem both in observational studies and in randomized clinical trials. And this was recently reviewed in the New England Journal of Medicine. Adherence can be determined by events that happen after randomization. Randomization guarantees exchangeability only at time 0, but after that, things can happen. The only way to adjust for that is using G methods, like inverse probability weighting, which is the approach that we used here. Okay, so to recap, we have three problems. First, uh, woman can be eligible multiple times. To solve that, we created a cohort every time a woman can be eligible. So we ended up creating 15 cohorts, one for each age of our age group, from 70 to 84. Second problem, the problem where a participant can be eligible for both groups. We solve it by cloning eligible woman and selecting only the person time that is compliant with each strategy. And the third problem, which comes from the artificial censoring in the step 2, was solved using inverse probability weighting. Okay, so this is what we found. We had 15 age-specific cohorts that we pulled together. We have about 1 million unique individuals that, because they could contribute to several age-specific cohorts, we ended up having 2.6 million individuals. That contributed 4.6 million person years to the stop screening strategy and 7.2 person years to the continue screening strategy. Here on the bottom, we have the cumulative incidence of breast cancer diagnosis, not mortality, breast cancer diagnosis. As expected, we see that in the continuous screening group, we have a higher incidence of breast cancer because we are actively looking for it. So it makes sense that in the continuous screening group, we have a much higher rate of cancer incidence. And this happens in both age groups. Now we will have to see whether this increase in the diagnosis of breast cancer translates into a change in breast cancer specific mortality or not. And this is the slide with the with the main results. Here we saw that in the younger age group, in the age group of 70 to 74, the hazard ratio of continuing screening versus stop screening at baseline was 0.78, which translates into an absolute difference of one fewer breast cancer death per 1,000 women. So it looks like it's slightly beneficial in this age group. On the other hand, in the older age group, in women aged 70 to 84, the hazard ratio was 1.00. So no effect, no beneficial effect. And the absolute difference was essentially null in this age group. We also estimated what type of treatments women require according to the group, or according to whether they were in this continuous screening or stop screening strategy. And we found that in both age groups, those that continue screening were more likely to receive breast conserving surgery as opposed to radical mastectomy. And they were also less likely to require chemotherapy as opposed to those in the stop screening group, which this can be seen as benefits of continuing screening. So this is my last slide, and just wanted to put in context our results with the results of prior clinical trials. What we knew from real randomized clinical trials was that in women aged 70 to 74, the benefit of continuous screening was reflected by a hazard ratio of 0.80, and in this same age group we found a hazard ratio of 0.78, which is very similar, and the absolute benefit was around one fewer breast cancer death per 1,000 women, and we found essentially the same, but even with a slightly narrower confidence interval. So here we are adding a slightly more precision to these estimates. For this older age group, for women over 75-year-old, we had no clue about coming from randomized clinical trials because they were not included in randomized clinical trials. But when we emulated our target trial in Medicare, we found that continuing screening did not offer any benefit in terms of breast cancer mortality. Okay, this was my last slide, and I hope this case study helps highlighting how using a proper methodology, we can use real world data to replicate what real randomized clinical trials have found and extend these inferences to groups of populations that were not included in those randomized clinical trials.